All right, so today we wanted to talk to you about, we've sort of shortened the title here because as you saw, it's actually quite long. But it's basically CDA to FHIR transforms, and this is basically in recognition of some project work that we did to develop a care plan for electronic care plan for pharmacists, and I think we did what at least we believe is the first dual CDA and FHIR implementation guide, and so we'll talk to you a little bit about that. I'm K.Sethi. I work at Lantana. I'm a manager of engineering and information analysis. I'm also a chair of the CQI work group, and a lot of my work is actually around quality and public health reporting. And with me is E.Parapini. He's an information analyst at Lantana and a CDA and FHIR expert. He was actually one of the lead architects of this transform and this sort of dual IG. So just a little bit about Lantana. We're a consulting company, and I like to say that sort of our mission, and this is sort of also our mission statement officially, we improve healthcare through the use of health IT, and we do this sort of in two primary domains, or what we call value propositions. One is sort of interoperability, and the other is sort of information extraction and using that for quality measurement, decision support, and things like that. All of that corporate speak really means is that we've been at the forefront of sort of standards and standards implementation for pretty much the last 10 years, and I'm pretty sure we hold the record for sending the largest contingent of people to HL7. So you guys are welcome. So a little bit about the project. We're basically this CDA FHIR transform was developed as part of an ONC high impact grant to address basically a gap that they saw in standard specifications today. So it was to develop an electronic care plan for pharmacists to be able to share data and also sort of to capture data in a structured format, and not just to that, but also pilot this standard for a period of three months with some vendors and a sort of provider network in North Carolina. So our collaborators with that were the Community Care of North Carolina, or CCNC, and two vendors, Pioneer RX and QS1. And CCNC is basically a provider network that sort of helps within North Carolina. They have certain projects to to sort of address Medicaid patients. So within the project, we had sort of three primary objectives. With this care plan, we wanted to improve sort of practice efficiency. We felt that a lot of the pharmacists and we wanted to eliminate sort of the duplication of effort that they were having to take. So we felt that an electronic care plan would address that. It would also sort of help pharmacists have greater engagement with their patients. I mean, often patients would have one interaction perhaps with their provider, but subsequent and multiple interactions with their pharmacists. And so this was a way to actually capture all of that data, and the pharmacists felt that they needed a place to capture the structured information. We also, one of the sort of major impacts that we felt this would have is improved clinical quality. Capturing this data structured data would at least provide sort of the first footbridge to actually getting sort of electronic automated quality measurement possible. And finally, obviously, also make this exchange sort of interoperable. So basically, I said this at the start of my presentation, that there was a gap within the standard specification, in which this electronic care plan really addressed. Also, this helps us sort of, because it is based on the care plan that is within the CCDA standard, which some of you may be familiar with. it's actually pretty interoperable with the data that may be coming out from the EHR. So with part of this project, so that's pretty much sort of all the background. There were three sort of key tools that we placed into the public domain. The first is sort of this, like I said, the dual sort of IGs, both a CDA and a FHIR implementation guide. And to my knowledge, or to our knowledge, I think this is the first time that anyone has done sort of this concurrent implementation guide where we have a CDA and a FHIR version. And to actually make both of those interoperable within themselves, we also developed bidirectional transforms that would let you implement either the FHIR or the CDA specification and then transfer or convert data between the two. And then finally, we had, we used sort of some of this background and developed training that we put out there for in the public domain. So I'm going to hand it off to Eric to talk a little bit more about sort of these work products and then give a live demo, which is not live at all.
It's a good effort though. So the first, the reason why we call this the first dual effort in both CDA and FHIR IG is because usually for FHIR, it's mapping backwards to existing CDA efforts. So the US core profiles, those were built off of the CCDA templates that exist. And this is the first time where we were using the CDA Care Plan, developing a Pharmacist care plan over top of that, and concurrently making a FHIR profile set that specifies a Pharmacist care plan. Both of these implementation guides had sample sets and everything that comes along with that to provide those live trainings we talked about earlier, and it really demonstrated a good pathway for vendors who are wanting to implement kind of the future standards, even though they've already invested in existing ones, so it doesn't feel like they have to restart everything. What really connected these two concurrently developed implementation guides were the CDA to FHIR transforms. There's kind of two sets, one that goes from CDA to FHIR and one that goes from FHIR to CDA. We released it all as, it's all open source, and we have it up on GitHub, and we included the link to that below if you want to adapt it into your, if you want to play around with it. Currently, these transforms really just target the Pharmacist care plan document types, but it also includes some of the templates that we used and extended through the existing consolidated CDA template sets or the existing US core ones. So if you are already implementing some US core profiles, you could definitely make use of some portions of this transform, if not the whole thing. So here is our quote-unquote live demo. It's a bit because I'm very paranoid and didn't want everything to fall apart during a presentation. So when you start off, let's say you are a vendor and you decided to develop a FHIR. You wanted to do this completely based off of FHIR, but you still wanted to work with competition, if you will, that decided to invest on the CDA side. So you receive this CDA-based document that's a Pharmacist care plan, and this is one of the samples that came through the implementation guide. So it's really marked up and a lot richer than I guess you'd see in the wild. And you would run that XSLT transformation through, and it would spit out this FHIR bundle. And now this FHIR bundle you can consume into your app, and it'll kind of work flawlessly, hopefully. So to kind of focus in on a few of the elements within that, you have the patient within the CDA side that's recorded as a record target. And you can see that one thing that we wanted to point out here was the way that IDs are often recorded differently. Identifiers within FHIR are different from IDs within the way it's represented in CDA. And so this actually gets transformed using the identifiers here, and you can see that we use, it kind of does, the XSLT does more than just take out something and plug it into another spot. It actually kind of intelligently consumes and translates more than just transposes. And so likewise with this is a CCDA problem observation, and it then gets transformed to the US core condition profile, and that all gets packaged into the bundle that can then be submitted to any server you'd like. Also part of the demo is that we load it through ClinFire, and you can see a graphical representation of this of this transformed document. And looking closer in, you can see that here's the condition that was put in, and it's all interconnected and related. And here you can dig a bit further into the transform condition and how it was all loaded onto the server.
And I think one important thing that I'll point out here is that the reason why we bring this up is also, and in sort of a live demo you could see this, but normally you wouldn't see sort of the kinds of conditions that you then find in the ClinFire sort of viewer. And that's sort of where the Pharmacist Care Plan component of it is coming up. And I think that what this transform really is showing is how you can sort of start from CDA if you've already implemented and have existing sort of investment in CDA and go towards FHIR, so sort of this bridge to that side, or you can directly jump, I hate these FHIR puns, but directly jump into FHIR and then work backwards towards sort of where the existing sort of federal investment or regulation lies within the CDA world. So it's really kind of showing this, hey, you don't have to actually pick and choose. Here's a way of doing both. Sure. So some of the sort of key findings that we had, I mentioned sort of the 3-month pilot period that we had within the sort of high impact grant that we had with the ONC. We really had sort of the reverse problem that we normally have with standards, where we have a standard and we're sort of begging people to come and implement it. And in this case, this isn't actually a standard yet, but we went from 2 vendors being interested at the start of the pilot to basically 22 vendors at the end of it. And it's not actually a standard yet, but they don't care. So we actually have we actually have the reverse problem. We're trying to actually find money to get this to be a standard, but we don't have that, but we have implementers. So when has that ever happened? I think that's the first. We've, some metrics sort of on, we've exchanged, or these pharmacies in this 3-month period have sent about, 4,000 messages to CCNC with this Pharmacist Care Plan. I think over 100 pharmacies basically are now sending this information. They've also been asking about, hey, we're just sending this information, we'd actually like to get it back also. And I think that's sort of where this will go next. I think we've sort of also seen, that I mentioned this a little preemptively, but this sort of dual effort sort of shows how, uptake for FHIR really can use both CDA as well. And just the end, sort of, you'll notice sort of that there's numbers here. This is sort of the raw numbers that I just shared. There's numbers here beyond August, and that's actually because we had such a successful pilot that we're actually continuing work with CCNC to develop this further and actually have more implementers of this standard, well, hopefully standard in the future. So these are sort of the latest numbers that we kind of had. We don't have numbers for November yet, but we actually do plan to continue this work in the future. Thank you so much. Thank you.